Today, we have a 3-year-old female mixed-breed dog who has been paralyzed since last night after jumping off the couch. She was perfectly normal prior to this event. On examination, she has no pain perception in her toes or legs. The team prepares for a CT scan to determine the cause of her sudden paralysis. Anesthesia has been administered intravenously, and the correct dosage has already been calculated. Let's place the endotracheal tube to maintain her airway during anesthesia. Testing the patency now. Good, it's clear. She's positioned on the V-trough to keep her stable. Attaching the heart and oxygen monitor. The dog is placed on the V-trough to maintain position. The heart and oxygen status are monitored continuously, as indicated by the box with a flashing green light. After preparing anesthesia for the scan, they move the dog into the CT scanner. The ventilator is set in the upper left corner, ensuring she's breathing properly. The control station is ready to set up CT parameters. Notice the infant monitor on the desk, allowing the team to keep an eye on her during the scan. The scanner creates slices as the dog moves through the unit. Each slice is shown on the console, reconstructing it into a 3D model for detailed viewing. After the scan, she is moved to the surgery table, which is covered with a red blanket heated with warm air. The heart monitor is reconnected to ensure constant monitoring. The large machine beside the table is the C-arm fluoroscope. Dr. Garner is working with a CT technician to identify lesions affecting the spinal cord. There is a white mass in the upper left quadrant of the screen. It is causing 80 to 90% compression of the spinal cord between the 12th and 13th thoracic vertebrae. The reddish color indicates bruising or hemorrhage, while the white is calcified disc material. The dog is surgically prepped while the owner is informed about the prognosis and surgical details. The C-arm is positioned over and under the dog. The table is radiolucent, allowing radiographs to pass through it during surgery. Dr. Garner and the team are now ready to proceed with the surgery to alleviate the spinal compression and give this dog the best chance for recovery. Dr. Garner reviews Zoe's CT images and determines that the bulk of the lesion is on the right side, so the surgical approach will be from that side. Large packs of sterilized instruments are brought to the table. Dr. Garner applies an adhesive antibacterial surgical barrier to Zoe to protect the surgical site. Using the C-arm fluoroscope, the exact surgical site is identified and marked with an instrument before the C-arm is moved away. The surgery begins by carefully moving the muscles away from the spinal bones to access the area. The bone is then removed using a high-speed drill and burr. The C-arm image reveals that the hemostat is 1 vertebra off the mark, prompting an adjustment. Gelpi retractors hold the muscles away from the spinal vertebrae. The articular facet connecting one vertebra to another is removed with double-action rongeurs. A periosteal elevator clears away the remaining small bits of muscle, exposing the white bone. The final inspection of the CT scan shows most of the disc material is in front of the disc space. The surgery continues with rongeurs removing bone anterior to the disc space, followed by periosteal elevators. 3 different drills are tested to Dr. Garner's satisfaction. The drill heats the tissues and creates bone dust, which is then irrigated and suctioned away by an assistant. The drill carefully brushes away bone in layers: the hard white cortex, the softer red marrow, and the inner white cortex, finally reaching the dura mater, the parchment-like covering of the spinal cord. Delicate rongeurs chip away bone next to the spinal cord, making room to tease out the offending disc material. Powerful magnification ensures precise movements to avoid trauma to the spinal canal. A custom-shaped cerumen loop goes under the spinal canal to remove the disc material. Delicate suction liberates the spinal cord from compression. Only small amounts of curd-like disc material can cause severe paralysis. A catheter flushes additional disc material from the spinal canal. The reflected muscles are sutured together, followed by the fatty subcutaneous tissues and the skin, which is sutured in a subcuticular fashion, leaving no exposed sutures. The antibacterial barrier is removed, and the surgical site is cleaned. Zoe is then taken back to the CT scanner to ensure the disc material has been removed. The ventilator is connected to assist Zoe's breathing. Images are rapidly sent to the control station, and the 3D rendering takes only a few minutes. Dr. Garner compares the before and after surgery images. The large white compression seen in the pre-surgery images has disappeared in the post-surgery images. The spinal cord is now free from the obstructing disc material. A correctional image shows the gap from the surgical approach. The 3D model is rotated to reveal the small surgical site in the vertebral wall where the disc material was removed. Zoe is now in recovery. Dr. Garner removes the endotracheal tube. Zoe is feeling no pain due to the medication. Although she is still paralyzed in the rear end, she now has a chance for recovery. With advanced technology and expert care, our veterinary team is dedicated to diagnosing and treating our furry patients with precision and compassion.